So sticking with the theme of oxygen, we have Professor Lankadeva from all the way across the world in Australia, and he's going to talk to us about renal hypoxia during cardiopulmonary bypass. He's the head of the Translational Cardiovascular and Renal Research Group at the Florey Institute of Neuroscience and Mental Health, and he gave a fabulous talk yesterday, and I'm looking forward to more of the same.
Great to be back up here again. Yesterday, I spoke about the brain and how cardiac surgery could injure the brain and the mechanisms and the development of some clinical biomarkers. Today, I'm going to be talking about the kidneys, and I can definitely tell you that there is no dark oxygen production in the kidneys. But it is really important to really understand the mechanisms by which these vital organs are injured during cardiac surgery, because this really is the pathway for better diagnostic and therapeutic discovery. Okay, now we know that over 2 million cardiac surgical procedures using cardiopulmonary bypass is performed each year. And we heard from Professor Landoni's talk yesterday that the incidence of acute kidney injury is around 30% in this population, which significantly increases short-term morbidity and mortality. However, it's also becoming very obvious now that patients that survive even short or acute or mild episodes of acute kidney injury are predisposed to a greater risk of developing chronic kidney disease and end-stage renal disease in later life. Unfortunately, the pathophysiology of cardiac surgery-associated acute kidney injury remains unclear, so effective interventions has not been developed. Currently, there is really no therapies except for conservative therapies, which means we, refrain from nephrotoxic drugs and just hope the kidneys recover, or in extreme cases, they're put through renal replacement therapy. And if you look at the current diagnostics of acute kidney injury, it relies on markers of renal damage that has been done, like increase in serum creatinine, oliguria. Really, increase in serum creatinine doesn't usually happen until 50% of kidney function is lost. So there really is a need to do better diagnostics. But an understanding of the mechanisms is critical for this. Now, I'm going to talk to you about a region of the kidney called the renal medulla, which is the inner region of the kidney. We believe this region of the kidney is most susceptible to hypoxia in pathophysiological settings, like cardiopulmonary bypass. Now, why should we care about renal medullary tissue hypoxia? Well, if there is hypoxia in this region, it could lead to ATP depletion, mitochondrial dysfunction, oxidative stress, inflammation, apoptosis, cellular cell arrest cycles, and tubular injury. All of these mechanisms together could precipitate in the functional deficits that manifest as acute kidney injury. Now, why is the renal medulla particularly most susceptible to hypoxia? Well, if you look at the physiology and anatomy of this region, it's got a relatively low blood flow compared to the renal cortex. There's limited oxygen diffusion due to low capillary density in this region. And there is also this phenomenon called shunting of oxygen. When you think about the descending vasa recta, which is the primary blood supply to the medulla, the arteries and veins are very thin and they're embedded against each other. So oxygen is stolen from the arteries into the veins even before it gets to the target region. And also, this region has the thick ascending limb of the loop of Henle. If you remember what the nephron looks like, this area has a high metabolic demand due to active sodium reabsorption. So we believe all these factors contribute to the renal medulla being particularly more susceptible to hypoxia. Okay, question one. We wanted to find out whether cardiopulmonary bypass causes renal medullary tissue hypoxia in the kidneys. Now, obviously, we cannot do this in humans. There's no way in which we can meaningfully assess this region in humans going through bypass. So this necessitates the development of clinically meaningful animal models for us to assess internal vital organs. Now, we have co-designed a world-first clinically relevant model in sheep. Now, don't go type this in ChatGPT. If you write the word sheep model, this is what comes up. That is not what they look like. We're going to use a schematic and show this. The reason why we use sheep is because we can assess multiple vital organs simultaneously. We can instrument the brain, we can instrument the cardiovascular system, the heart, the lungs, the liver, the kidneys. And most importantly, we can actually assess these variables in the non-anesthetized state and then track it as they go into general anesthesia, onto cardiopulmonary bypass, weaning from bypass, onto the sedation period, to the ICU environment, and really track internal vital organ function continuously over clinically appropriate time periods to understand how disease mechanisms, the temporal onset of disease mechanisms. Okay, to do this, we had to really pioneer a new surgical technique. This preparatory surgery is done to the sheep before they go through bypass, usually a week before, where we do abdominal surgery under general anesthesia, and we instrument the kidneys to assess the renal macro and microcirculation. So we put a flow probe around the renal artery. Let me just, flow probe around the renal artery to measure total kidney blood flow directly. We can cannulate the renal vein so we can take blood, and then we can do blood gases on the renal venous blood, arterial blood, and using renal blood flow, we can calculate renal oxygen delivery, consumption, and extraction ratio. Then we can also insert these combination fiber optic probes into the renal cortex and the renal medulla, which gives us a really nice assessment of tissue perfusion, oxygenation, and temperature. So you can see we can get a really nice measure of the renal macro and microcirculation, and then track this in the conscious animal onto general anesthesia, bypass, and then out again. So with bringing together a great team of cardiac surgeons, clinical perfusionists, anesthesiologists, interstitial physicians, nephrologists, we really created this study protocol that we believe simulates what happens in a human going through bypass. There's conscious period, general anesthesia, 2 hours of aortic cross-clamp and cardioplasia, weaning from bypass, sedation, and then 48 hours in the ICU, which is the clinical window for the development of acute kidney injury. We even took it a step further and actually tracked how the kidneys behaved for 30 days after bypass, which I'll show you later. Since the conception of this model, we have repeatedly showed that undergoing cardiopulmonary bypass under current perfusion conditions causes renal medullary tissue hypoxia. This is mediated in a two-step fashion. There's general anesthesia, which reduces renal blood flow and renal oxygen delivery and increases renal vascular resistance. And then going through bypass is almost like a second hit to this kidney, where renal blood flow plummets even further, and renal tissue hypoxia develops in the renal medulla for a period of 2 hours on bypass. Now, really excitingly, we have advanced this forward to see whether hypoxia is sustained in the post-operative environment when acute kidney injury develops. So this is really new data. I want to congratulate my PhD student, Dr. Tako Furukawa, who's an intensivist and anesthesiologist. This is his first PhD chapter that was just published in anesthesiology a month ago, where we showed that the intraoperative renal medullary hypoxia is sustained all the way up until 48 hours after bypass. And there is an incidence of acute kidney injury of 42% in these animals going through. It's a clinically relevant incidence rate. And renal medullary hypoxia now is sustained in the 48 hours, and we track them all the way to 4 weeks afterwards, and hypoxia persists in these kidneys. Now, if you look at renal function, or AKI, it resolves after 48 hours. All these animals recover their renal function after 48 hours, but renal tissue hypoxia persists. Now, it starts with the renal medulla. After 2 weeks after bypass, there's a switch into the renal cortex. Now, there's renal cortical tissue hypoxia. The fascinating thing is the renal macrocirculation normalizes by about 8 hours into the postoperative period. So renal blood flow is normal, but there's uncoupling of the renal macro and microcirculation that happens after bypass. More concerningly, if you were to take the kidneys at necropsy and look at histopathology, now here are kidneys of animals that has completely normal renal function, but if you look at the kidneys 30 days after cardiopulmonary bypass, there's pronounced structural injury. That's characterized by peritubular infiltration of leukocytes, interstitial fibrosis, there's cellular cast, there's focal acute tubular necrosis, but renal function is normal. But as I mentioned, patients that develop acute kidney injury do transition into chronic kidney disease. And if you look at the structural footprint of inflammation, fibrosis, cellular cast, focal ATN, these are all involved in the pathophysiological sequelae of AKI to CKD transition. So now, this again further shows us that current diagnostics, relying on creatinine, relying on urinary output to diagnose kidney disease is suboptimal. We need better diagnostics. Creatinine is not sensitive enough to pick up the structural injury that is pertinent. So we are going to be using amino acid loading, just like Professor Landoni. So now our studies are actually looking at amino acid loading to actually look at renal functional reserve before bypass and then weekly after bypass to see whether functional reserve could be used to diagnose subclinical kidney injury. Right, so we do need a better biomarker, so that should be our next focus. So the next question is, can we develop a non-invasive way to detect renal medullary hypoxia during cardiopulmonary bypass? Now here we are looking at a transverse section taken toward the inner base of a rat medulla, where we have immunohistochemically labeled the descending vasa recta. Remember, that's the primary blood supply to the renal medulla in red, and the collecting ducts in blue. You can appreciate that the descending vasa recta and the collecting ducts are positioned close and symmetrically around each other. Due to this intimate anatomical relationship, we hypothesize that oxygen levels in the renal medulla, which would be high, or higher than the urine anyway, would diffuse into the urine in the collecting ducts via a concentration gradient. Why does it matter? It matters because after that, that gets passed down the ureter into our bladder. Then we got together with an industry partner, Oxford Optronics, using the same fiber optic technology. We developed this versatile probe that can be tunneled through a standard Foley bladder catheter, so it sits at the tip of the bladder catheter in direct contact with the patient's bladder urine. And we hypothesized that if bladder urinary oxygenation gives us a good indication of what's happening in the renal medulla, this would be a non-invasive biomarker of acute kidney injury. Now, I know what you guys are thinking, how on earth is catheterizing the bladder non-invasive? Now, who the hell wants a bladder catheter? But everyone who's seen cardiac surgery knows insertion of a catheter in the bladder is routine practice in patients going through heart surgery, so the catheter is already there. So inserting this probe is non-invasive in this setting. Then we went back to the drawing board with we got a really good sheep model of septic acute kidney injury that develops over 24 hours. And we started simultaneously measuring renal medullary oxygenation and bladder urinary oxygenation during 24 hours of acute kidney injury development in sepsis. And we showed that the reductions in renal medullary tissue oxygenation is closely paralleled by reductions in bladder urinary oxygenation during the development of acute kidney injury, which happens after 24 hours in the sepsis model. There is a positive and significant correlation. Took it another step forward and started validating this against current clinical diagnostics like serum creatinine, which only elevates in septic acute kidney injury after 24 hours. And urinary NGAL, which is a marker of tubular injury, increases after 8 hours, but you can detect renal medullary tissue oxygen deficits from the first hour of infection. Okay, this gave us enough equipoise to now go into our human ethics research committees and try to do this in patients undergoing cardiopulmonary bypass at one of our affiliated hospitals at Monash Health. This is 65 patients going through CABG or valve replacement or repair procedures. And then about 40% of these patients developed acute kidney injury. And we started measuring bladder urinary oxygenation from the insertion of the bladder catheter from that point in the operating theater. So here's the results. We are looking at pre-op and then during hypothermic bypass, rewarming, and then intervening, and we see that both groups show temporal reductions in medullary tissue oxygenation. However, the group that developed acute kidney injury had larger reductions and also spent more time in hypoxic regions during the operation. And these patients developed acute kidney injury. Okay, a diagnosis is great, but what the hell are we going to do about it, right? I mean, well, the next question was, can we alter clinical perfusion conditions using the heart-lung machine to improve oxygen levels in the medulla? So this has been a labor of love for me over the last, 8 years. So we started doing various things, right? I mean, we started increasing pump flow. And yes, okay, this brought about a 65% restoration in medullary tissue oxygenation. We started increasing mean arterial pressure, and that brought about a 70% restoration in medullary oxygenation. But increasing these things too much really upsets the cardiac surgeons, right? I mean, they're like, well, come on, guys. We don't want to operate with high flow and high pressure all the time. Anyway, so we started looking at other things, increasing blood hemoglobin levels, right? Like the TRIX trial. Did absolutely nothing. We started even inducing this artificial pulsatile flow on cardiopulmonary bypass, a pulse pressure of about 20 millimeters of mercury. Did nothing. We started inducing moderate hypothermia, cooling these animals to 30 degrees. Did absolutely nothing. So we thought, well, we got some signals, but the surgeons aren't happy, right? I mean, it's very hard to make them happy. It's very important we do. So let's try a combination intervention. Let's try increasing pump flow by about 10%, increasing blood pressure by about 15%, and maybe this combination intervention could be better. Okay, it was better. So when we did this intervention, simultaneously increasing pump flow and increasing blood pressure, we can restore medullary tissue oxygenation during bypass 95% restoration in oxygen levels to the renal medulla during surgery. However, the choice of vasopressor matters. The choice of vasopressor matters. If you use noradrenaline, this is not going to be good for the kidneys. Noradrenaline is really bad. It exacerbates renal medullary tissue hypoxia. We've seen this in sepsis time and time again, and now we are seeing this in cardiopulmonary bypass. There's none of the vasopressors like methamphetamine, noradrenaline, phenylephrine, vasopressin, or angiotensin improves medullary oxygenation, but noradrenaline makes it worse. So we will now confirm this using non-invasive microvascular imaging. Giving noradrenaline during cardiopulmonary bypass really shuts down the microcirculation in the kidneys during bypass. Okay, next question. Is bladder urinary oxygenation just a marker, or is it response to the clinical interventions that would alter medullary tissue oxygenation? So we started doing this clinical trial, so we're now translating what we see in the sheep to humans. This intervention of combination intervention of increasing pump flow to 3 liters per minute and blood pressure to 80 millimeters of mercury using methamphetamine. This is 20 patients going through CABG or valve replacement and repair procedures. So this is a within-patient crossover study, and this is just to show that we achieved our target blood pressure and our pump flow, and we are starting to measure bladder urinary oxygenation in these patients. And what we're seeing is doing this combination intervention does bring about significant increases in bladder urinary oxygenation in patients going through cardiopulmonary bypass, which suggests that this is a good marker not just of risk, but sensitive to therapeutic interventions. We started looking at other pharmacological interventions like dexmedetomidine. I showed the effects of dexmedetomidine in the brain. Now I'm showing the effects of dexmedetomidine in the kidneys. Did absolutely nothing to improve the microcirculation in the kidneys. Dexmedetomidine did not do anything. For intensive care physicians are very familiar with this. This is an alpha-2 agonist. It's used to reduce delirium and agitation. It's supposed to be a centrally acting sympatholytic and anti-inflammatory agent. And I was a huge fan of this drug until we did this study, and I got even more sad when I saw the histopathology. Not only did it not improve the microcirculation, but there was more prominent histopathological injury in the kidneys of the animals that were treated with dexmedetomidine. Okay, then we kind of went around and started doing these observational studies in critical illness, using bladder urinary oxygenation to show that dexmedetomidine in critical ill patients recovering from sedation also compromises bladder urinary oxygenation in a dose-dependent manner. And if you look at drugs like furosemide, which is given as a diuretic to septic patients, this increases medullary tissue oxygenation because it releases, prevents sodium reabsorption. So it does increase bladder urinary oxygenation. So this marker is sensitive to therapeutic interventions. Okay, to summarize, does renal medullary hypoxia occur during cardiopulmonary bypass? We're pretty darn sure it does. And there's about 60 to 70% reduction in medullary tissue oxygenation. And this is driven by reductions in renal blood flow, increases in renal vascular resistance, reductions in renal oxygen delivery. Can we develop a non-invasive biomarker to detect renal medullary tissue hypoxia in patients? We believe continuous measurement of bladder urinary oxygenation may provide a real-time estimate of renal medullary tissue oxygenation during cardiopulmonary bypass. Can perfusion conditions be modified using the heart-lung machine to improve medullary tissue oxygenation? We believe it can. If you use a combination intervention of increasing target pump flow and pressure, this seems to normalize renal medullary tissue oxygenation. Can bladder urinary oxygenation detect changes in medullary tissue oxygenation in response to interventions? We believe it can. We have now done furosemide, we've done changes in inspired oxygen fraction, noradrenaline, which was recently published, showing that noradrenaline in the post-operative environment plummets bladder urinary oxygenation in patients recovering from cardiopulmonary bypass. So we believe it's not just a marker of risk. We believe we can use this to guide clinical interventions in the operating theater and also in the ICU to offer better renal protection during cardiopulmonary bypass. So with that, I would also like to, we're very fortunate to receive this $4.9 million grant. We've got a new disease-modifying therapeutic, which we believe is both neuroprotective and renoprotective. So we're going to be advancing this forward to multi-center clinical trials over the next 5 years. And it's going to be my absolute privilege to lead this group of scientists as well as clinicians. Like we got cardiac surgeons, cardiologists, nephrologists, intensive care physicians, perfusionists, neuropsychiatrists to do multi-center trials across Austin Health. Royal Melbourne Hospital, Alfred, Royal Adelaide, and Monash over the next 5 years. So watch this space. So with that, I'd like to thank my wonderful team. These studies are very complicated, very labor intensive, and it requires big groups of people working together. There's a great group of research assistants, students, clinicians, postdocs, RAs, and of course our funding bodies, without whom none of this would be possible. And I would like to end by paying a special tribute to two people. These are two of my work fathers that we lost within the last month. Mr. Bruno Marino, who is a brilliant clinical perfusionist, who was unfortunately diagnosed with pancreatic cancer towards the end of last year, and he succumbed to cancer about a month ago. Bruno was pivotal in the conception of this model. We didn't have funding. He donated 2 heart-lung machines as well as his time pro bono to get this work started and ongoing. And the other work father I lost 2 days ago is, of course, Professor Renal, who is the most preeminent intensive care physician in the world with over 2,000 papers and over 200,000 citations. He had a sudden cardiac arrest, and he did not recover well from this, and he passed away two days ago, and it's been a terrible loss to our intensive care community in Australia and most likely to the world. Lost a terrible, amazing mentor, an amazing work father. He's always empowered the next generation of clinicians and scientists to push boundaries and not give up when things get hard. And his legacy will continue through the work we do, the knowledge we create, and the lives of the patients we touch through our translational discoveries. So rest in peace, Renal. Thank you very much.
All right, do we have questions from the audience after that very intriguing talk?
Interesting. Yes. Yeah, it's an interesting presentation. I like the transition through it and showing. It looks like there's something that occurs, after the cardiopulmonary bypass, where the body starts to do a healing process and it recovers. I thought that was interesting. I was a little surprised that pulsatile flow didn't really give a response. That kind of surprised me. So what I got out of it is like the majority of us use needle synephrine in our cases, which was a little bit better. But any core pressors that constrict flow to the kidneys obviously is affecting it. It looks like. So maybe we should look at transitioning to vasopressin in all of our cases, because that's what I've always used, needle synephrine, and then maybe even given Lasix or furosemide, in the process post-op, just to help with that oxygenation, because that's what it looked like you had the best results with there.
I couldn't agree more. I think non-catecholamine vasopressors are the way to go, and I believe this is the way to go in not just perioperative medicine, but also intensive care medicine. So vasopressin, yes, I think it's a vasopressor that does not further compromise the microcirculation. But one of the problems with vasopressin is it's very hard to titrate. Yes. So we found that in our studies as well as it's a common issue in clinical cases. So I think angiotensin II might be a better option, because angiotensin II can be better titrated. I know it's a little bit more costly. I guess that's the issue there. But I think non-catecholamine vasopressors are the way to go. Yep.
Okay. Thank you very much.
All right. One more question here.
Thanks for the great insight. If everyone is seeing this hypoxia and renal hypoxia, why is there only a certain amount of people reacting to it? Is there something else going on? Is there coronary disease? Arterial disease or?
Yep. So I think the pre-existing comorbidities play a role in the development of acute kidney injury. We know that if you have chronic kidney disease already, coming into surgery, obviously there's a higher risk of transitioning into acute kidney injury and then more progressive chronic kidney disease later on. It looks like hypoxia does develop in all the patients, but I think certain patients that has compromised autoregulation will be compromised more. And I think bypass is also a bad setting for renal autoregulation. The lack of pulsatility, cooling, the priming circuit can all interfere with autoregulation. But I think patients coming into the operation with more impairments in renal autoregulation are prone to more hypoxia. And the higher the degree of hypoxia, the problem is when you start weaning from bypass and cardiac output starts coming back, you're going to get a higher degree of ischemia reperfusion injury. So I think the degree of hypoxia also matters, and the time period you spend in hypoxia also matters.
Did you see some people with more hypoxia than less?
Yeah. So in the clinical study, the patients that went on to develop acute kidney injury were the ones that had a higher magnitude of hypoxia and also spend more time in those hypoxic regions in bypass, as indirectly estimated by bladder urinary oxygenation.
Yeah, one other thing that kind of comes to mind is preoperatively when they go to the cath lab and they get the dyes, we always see a rise in the creatinines. Is there anything you associate to that provoking the situation in addition?
I believe it would. So I think that's another etiology that has been attributed to renal medullary tissue hypoxia. We haven't looked at that directly, but radio contrast induced nephropathy, I think radio contrast would also compromise and really damage the microcirculation. That's been showed by other groups. So yes, I think it'll probably be a 2-3 hit hypothesis. Then you could probably get a hit with that radio contrast and then go to bypass and you get another hit. So yeah, I agree. But that'll be another interesting area to look into. Yeah, good question.
Thanks. Hey, that was really cool. One of the things I've seen over the years is that you mentioned pulsatile flow, and in the 80s we were experimenting with that. And what we found was that in a closed circuit with a bag system where you maintained a CVP in the positive range, and with pulsatility, you were able to influence the urine output up to about 32 degrees. When we got below 32 degrees, it was too much energy going into the system. One of the things that I'm hearing in the increased flow is probably a backup into the venous system, which also allows for the kidney not to shut down. I see most people going on bypass with negatives in the CVP, and also you're kind of shutting down the kidney immediately. And one of the other contributing factors is that the saline washes that they're using for valves and stuff like that, when it comes back, high sodium. And it kind of reminds me of the sailor trying to drink water in the sea. He shuts down his kidneys. So there's those two things that I'm observing, that sodium and low CVP and vacuum and open systems all are contributing to this in one way or another.
No, I couldn't agree more. And I'm going to also say, yeah, like pulsatility, we shouldn't overrule it, because one thing we did detect is, although we simulated it, the DPDT, the natural curve of a beating heart is, we didn't achieve that, right? I mean, I think John Fraser's group in Australia is looking into this, using algorithms to really simulate this, DPDT relationship and the natural pulsatility. So I think we shouldn't overrule pulsatility, at least with the thing we can generate through the heart-lung machine. We couldn't. But I do agree with the flow as well. I think just relying on high flow is probably not the way to go. It also increases, well, one, it makes the surgeon unhappy. Also, it increases turbulent flow with dislodged plaques, send it to the brain. I mean, in patients with atherosclerosis. So I think if I was to think, just non-pharmacological is not the way to go. I think the combination of this kind of non-pharmacological interventions with a pharmacological intervention, whether it's amino acids or some of the therapeutics we are finding, I think that's probably the safest way to go forward.
Yeah, I agree with you. I think one of the things that we saw with the pulsatile flow was the stroke volume difference. And we're using at Stanford Pediatrics, and stroke volume of 5 cc's. It's like, no, you can't do it. So laminar flow and CVP is kind of the way we have to deal with it nowadays. So I agree. That was a great paper. Thanks. Very interesting.
Thank you.
Thank you. Very interesting talk. I just had the one comment. I've been doing this a while, and I've seen things kind of flow back and forth in perfusion. And we went to periods where we had very low prime circuits. And a lot of us have blood conservation programs now that we're trying to minimize dilution and such. But it occurs to me that one of the things that I think sometimes gets overlooked is that in order to maintain normal renal function, proper hydration is absolutely necessary. And I wonder if you looked at changes of hydration at all in any of these studies.
No, we did. So we actually had a group that was, obviously the animals were fasted overnight. But again, we didn't do it in humans, we did it in the animals, and we gave her continuous infusion of balanced crystalloid, like 1 ml per kg per hour over 24 hours, and then subjected them to bypass. Still hypoxia, still kidney injury, still structural deficits. So at least in preclinical evidence, the level of hydration didn't seem to matter.
Okay, in the interest of time, we're going to have to pause there and continue this in the break. But let's thank the speaker again.
Thank you very much.